Coronoid fracture rarely occur in isolation. It is associated with elbow dislocation. Coronoid is a primary restraint for elbow subluxation dislocation. Intermedial coronoid may result in posteromedial rotatory instability. Coronoid fracture with a stable elbow, amenable for non-operative management with short period of immobilization. Associated fracture injuries, cerebral triad, that is coronoid fracture, radial head fracture, and elbow dislocation with LCL avulsion from the humeral epicondyle. Olecranon fracture dislocation, often a large coronoid fragment. Posteromedial rotatory instability happens when there is a varus force with fracture of the anteromedial facet of the coronoid and LCL disruption. Posterolateral instability when the coronoid tip is fractured with a radial head fracture and LCL injury. Regan-Murray classification: tip less than 50%, more than 50% of coronoid. Anteromedial facet caused by varus posteromedial rotatory force. ORIF if unstable, anteromedial facet fractures, or with posteromedial instability or fracture dislocation or cerebral triad. Options are number 1, cerclage wire, number 2, suture fixation through drill holes, number 3, retrograde screws, number 4, plate fixation. Ligament repair is always indicated. Early active motion is post-operative period. Hinge elbow external fixator should be applied if needed. Consider restricting elbow abduction to prevent varus movement at the elbow joint. Complications: recurrent elbow instability, elbow stiffness, atrophic ossification, post-traumatic arthrosis.